Hello everyone. Before we begin today, I would like to acknowledge the traditional custodians of the land we are on, the Whadjuk Noongar people, and pay my respects to elders past and present. My name is Joanne Haro and I'm a research officer with the Australian Indigenous HealthInfoNet, and I work on the Australian Indigenous Alcohol and Other Drugs Knowledge Centre project. Thank you for joining our webinar today. I'm pleased to introduce our guest presenters, Professor Ted Wilkes and Professor Dennis Gray from the National Drug Institute, NG, based at Curtin University in Perth. NG are an important long-term collaborating partner with the Knowledge Centre project, and Dennis and Ted are active members on our national reference group. Associate Professor Ted Wilkes is a Noongar man from Western Australia and is currently the leader of the Aboriginal Research Program at ENDRI. He's playing an active role in Aboriginal capacity building and research and its application. Professor Wilkes is a member of the Australian National Advisory Council on Alcohol and Drugs and was previously a member of the Australian National Council on Drugs and chair of the National Indigenous Drug and Alcohol Committee. In 2014, Professor Wilkes was made a member of the Order of Australia for distinguished service to the Indigenous community as a leading researcher in the area of public health and welfare and for services to young people in Western Australia and for the provision of legal support services. Professor Dennis Gray is Deputy Director at ENDRI and a leader of the Institute's Aboriginal Research Program. Professor Gray has a long history of conducting collaborative research with Aboriginal community-controlled organisations and has published extensively on Aboriginal alcohol and other drug issues. His most recent work is focused upon the provision of alcohol and other drug services and on enhancing options for the management of alcohol and other drug-related problems in Aboriginal community-controlled health services. The theme for today's webinar is Harnessing Good Intentions, Addressing Harmful Alcohol and Other Drug Use Among Aboriginal Australians. So we'll have about 10 to 15 minutes at the end to field questions. If you'd like to type them in the chat box at the end of on your dashboard. So I'm going to hand it over to Ted and Dennis now. I'll put it on full screen so you can see. So just hand over to Ted.
Well, here we are, Dennis. Thank you, Joanne. I might try and, I think we've got to make sure we fit in the screen, so we'll get in a bit closer. But I'd just like to thank Joanne for the acknowledgement of country. And as a Noongar man, I feel as though it's my obligation to just do a welcome to country so I can make myself feel a bit more comfortable. And for my colleague, Professor Dennis Gray, to also maybe warm to the spirit of the Noongar people in this discussion. But Kaya, Wanju, Nich Wachak Noongar Maman, Ngan Mam Buja, Wachak Buja, Nunuk Ngananyini, Wachak Buja, Kaya, Pua Wago, Miao Jinning and Nija, Wachak Buja, Pua Wago, Miao Jinning and Nija, Professor Dennis Gray. I've asked the spirit of the Noongar people to just bless us while we go through this process, imparting information to others to enhance the capacity for Aboriginal Australians to seek out and find a better quality of life is something that we should all cherish, because we have a fair way to go. Our life and our disadvantage is quite marked in this country, and those of us that are the leaders and our colleagues in non-Aboriginal Australia, people like me would beseech our non-Aboriginal colleagues to join us to ensure that our battle to seek out that quality of life is something that we earn in the shorter term rather than the longer term. But our discussion today is going to be led by a premise of harnessing the good intentions of one another. And unless we can at least acknowledge that there are human beings in this country that would want to express themselves as to how we might we might intervene, or we might find those pathways to a better quality of life for Aboriginal Australians, well then we might find it more difficult to do that. So harnessing the good intentions of one another and harnessing the good intentions of non-Aboriginal Australians is something that I've been doing all my life. I've fully realised that we cannot, as Aboriginals on our own, Aboriginal people on our own, complete the task at hand, and we do need buy-in from our governments and from the mainstream systems, and not only our governments today, but also to the philanthropic and to the private companies and the private interests around Australia as well. But I'll hand over to Dennis to maybe kick us off in a more academic way and introduce himself as well.
Okay, thanks Ted. Ted and I have worked together for a long time, and it's always a pleasure to present with him. As Ted said, what we're concerned about in this talk is harnessing the good intentions. But I think firstly we've got to think about good intentions for what? People recognise that there's a higher levels of harmful alcohol and other drug use amongst Aboriginal people. But often they go from that to thinking that those problems exist amongst all Aboriginal people. I think the starting point should be that one of the things we need to recognise is that most Aboriginal people that use alcohol, for example, do so safely. It's a minority of people that have problems, but a lot of those people have significant problems. And I think there are very few people in Australian society that wouldn't want to do something about it. But the question becomes what? And you know what we've had in this country is a long history of non-Aboriginal people thinking that they've got the solutions to the issues of harmful alcohol and other drug use amongst Aboriginal people, as they think they've got the solutions to a whole range of things. And I think, as Ted said, one of our premises is that what we need to do is harness those good intentions and have people working with Aboriginal people and not for them.
Yeah, and what we also understand are there are many connectors in relation to how we might do this. And first of all, obviously, we have to have the knowledge that alcohol and drugs is a cause and effect of many things. We now understand alcohol and drugs as a social phenomena, which you can call a virus, you can call a disease. People try to find these terms to express what it really is, but it's a reaction sometimes to what's happening around you. And as Dennis has stated, there's a minority, and it's a significant minority of people that are causing harm to themselves as Aboriginal Australians. And because of the stereotypes that have come forth in history, we Aboriginal Australians in the broader context are then marginalised and stereotyped as having this dependence on alcohol and other drugs, which is something that becomes normalised. And far from it, alcohol and drugs is not a normal part of our way of living, never was, and should not be a normal part of the common good that Aboriginal Australians require. But let me say this to you. Alcohol and drugs, for all intent and purpose, is being used by many human beings in this country, and in most cases for recreational reasons. But we in our work understand that it's also used for other means, and people use it to medicate and to find an out, to find a way to cope with another day of what people might call is the oppression of living in a Western system that we Aboriginal people have now had to adjust to for the last 3 or 4 generations. And some of us are doing okay, some of us are doing very well, but others are finding it very difficult. It's like we understand that some of the people that are caught up in the trauma or the intergenerational trauma of living here in Australia as Indigenous peoples are more vulnerable than others. And for instance, the stolen generations, which we've now studied and have a context of, are more vulnerable than other Aboriginal Australians, and particularly other non-Aboriginal Australians.
I think Ted touched on some important things there, and I think one of the things is the social context of alcohol and other drug use. A long time ago, a psychologist named Zinberg said that if you want to understand drug use in a community, you have to understand the nature of the drug itself, and we deal mostly with alcohol. You've got to understand the characteristics of the individual, and you've got to understand their social setting. And I think there are individual characteristics and characteristics of social settings which protect people. Sorry, we're having a bit of a technical problem here.
No,
Sorry about that. So there are characteristics of individuals and characteristics of their social settings which either protect people against harmful levels of use or incline them towards it. And I think that you can't understand harmful levels of use amongst Aboriginal people without having an understanding of the history that's brought people to where they are, the social disadvantage that people face as a result of that history, and then the personal impact that it has on people. And we know that there are high levels of stress amongst Aboriginal people caused by these environments in which they live. And as Ted said, one of the things it does is cause people to turn to alcohol and other drugs to medicate against those harmful environments.
And of course, Australia is a big country, and far be it for Dennis and I are both social scientists and have an anthropology background, so we're very familiar with the history and the prehistory of what's happened in Australia. And you know, for us to know that a couple of hundred years ago, when others came to this country, there were over 500 different languages in this country. And today we've lost a fair few of those, but the diversity within Aboriginal Australia is still quite marked and remarkable. And people in history have called us a homogenous population. Far from it. We have a diversity which is similar to countries like Europe, where languages next door aren't understood, where some of the traditions, the food and the customs are similar, but not exactly. And we Aboriginal Australians today hold on to our diversity and to our cultural cliques, for want of a better way. We are very, very tribal in many ways. So some of the ways that we might want to intervene with interventions around how to best minimise the harmful effects of alcohol and drugs might differ throughout the country. But there are some core and fundamental issues which we have to deal with, and it might be that alcohol causes domestic violence. If we as we do understand that, yeah, if you've been drinking alcohol or on other substances and using it as a medicate, when you come out of it, we know that people come out with emotional feelings that are quite marked, sometimes quite angry. And yeah, so alcohol and other drugs does play a role in issues within families, domestic violence, child abuse, other sorts of violence between men. It also causes, as I indicated before, the stereotypes that non-Aboriginal people are able to throw around with reckless abandon. And for those reasons, we have to organise interventions. And some of those interventions, well, how do you protect women? How do you protect men from themselves? How do you protect society in general from the misuse and the behaviour of people who have misused alcohol and other drugs? And so there's a, you know, we look at what happens at the national level, and we do have a national drug policy. And Dennis, those three pillars we talk about.
Well, we've got, as Ted said, we've got a national drug strategy, and we've also got a national Aboriginal and Torres Strait Islander people's drug strategy. And the idea behind those strategies is to minimise the harm that's caused by alcohol and other drugs. Now, we recognise that these drugs aren't going to go away, that people use them, and what we've got to do is reduce the harm as much as possible. And as part of that national drug strategy, there are what they call the 3 pillars. So there's supply reduction, which is aimed at controlling the availability of alcohol and other drugs. There's demand reduction, which is a focus on individuals and communities and what are the factors that cause people to use those drugs, those historical, those social inequalities that we just talked about. And then the 3rd pillar is harm reduction. That includes strategies like night patrols and sobering up shelters, where the idea is to take people who are intoxicated and get them off the street and put them somewhere safe so that they're not doing harm to themselves or others. But they're fundamental parts of that strategy. But one of the things that Ted mentioned about was the diversity of Aboriginal people. And a couple of years ago, Ted and I and some Aboriginal and non-Aboriginal colleagues did a review of the Aboriginal drug and alcohol treatment sector. I think one of the messages that came through loud and clear from people on the ground was that these national strategies are all very well, they're high sounding, but in some ways they're top down and they don't give enough flexibility to people on the ground to come up with their own solutions and what suits their communities. And you know, we've got national funding programs which are based on these broader strategies, and the money goes in silos, and on the ground the money might be for things that aren't important to a particular local community. And so what we've got to do is be responsive to communities on the ground.
Yep, and some of the ways we look at how we're going to do this is very complex, people. Let me tell you, you know, if you're trying to, you live in a city like Perth, and as an Aboriginal man, I'm connected through grandmothers and grandfathers to just about all of the people in Western Australia. I think a lot of us Aboriginal people actually have that in history, but it makes you wonder how we might intervene in places which we call remote and isolated Australia, how we might help Aboriginal people living in rural, regional Australia, and how we might help Aboriginal people living in cities and large towns. And so this diversity, it creates a want and a need for Aboriginal Australians, which sometimes needs to be taken differently. And in our studies around the areas of greatest need, we've identified not only this diversity, but we've also identified that geographically and historically that some Aboriginal region or regions where Aboriginal people have significant populations, and not only Aboriginal people, this crosses and cuts into just populations in general, but it's certainly quite stark for us who work in Aboriginal Australia to know that some Aboriginal regions or regions where Aboriginal people live are sadly lacking in resourcing. So we have to go to government and say it's an unequal distribution of the resources, and we need to make sure that we equalise or improve the resource allocation throughout Australia. So there's a lot to look at here. You know, and there's a lot to do. It's recognising that there are a lot of people working across the broad depth of Australia to try and get this right. So I will acknowledge my colleague here again, Dennis Gray, but there are other people. There are lots of Aboriginal leaders, and there are lots of non-Aboriginal colleagues who we work with that are trying to find the answers. Some of those answers, Dennis, I'm going to ask you to have a discussion about what works and what doesn't work. I mean, we talk about this, and maybe you might like to start that discussion.
Well, I think one of the fundamental things is that we know that the distress that's caused to people, one of the main reasons that people turn to alcohol and other drugs, is a result of the social environments in which they live. And you know, year after year, the reports of the steering committee looking at government service provision highlights the inequalities that Aboriginal people face. Now, for a long time, we've had the Closing the Gap program and its predecessors. But I think one of the realities is that no government of either side of politics has actually put in the resources that are needed to reduce Aboriginal inequality as we would like to see it. I think that it's fundamental that we address those underlying social determinants. We can't just focus on treatment of the problems, and we can't just focus on things like getting people off the streets when they're intoxicated. What we've got to do is address those underlying fundamental issues. Otherwise, the treatment programs are just band-aids. What we need is a broad strategies to address the underlying social determinants. We need preventive programs, particularly early childhood intervention programs, so that young people don't get started down this path. We've got to build resilience in young people so that they don't need to fall back on the use of alcohol and drugs. We need treatment programs. We know that treatment works. I think that the reality, though, is a lot of people expect that someone goes into a treatment program and they're going to come out cured, as if they'd gone into hospital for pneumonia or something, and they'd been treated and they come out and they're fine. But the reality about alcohol and other drug dependence is it's a chronic relapsing position, more akin to diabetes. When you treat someone, what you do is get them in, you stabilise them, and then the idea is to follow them up and prevent the reality is people do relapse, and what we've got to do is minimise those occasions of relapse and try to keep them as safe as possible. So we need programs for that. The other thing we need is, as Ted was talking about, things like domestic violence. I think what we need to do is put in place programs which address the harms that users of alcohol do to others. We know about people consuming lots of alcohol, becoming violent and hurting themselves or others in fights, or jumping into a motor vehicle and injuring themselves and others. And what we've got to do is come up with programs to protect other people from the harms that people who are dependent on alcohol cause.
Yeah. I also wanted you to mention the broader context, which we work with people like John Boffer and Donna up in Congress in Alice Springs, but there are broader implications for the whole population of Australia. But for Aboriginal Australians, we have some knowledge about price and how the monetary value on a bottle of wine or on a can of alcohol might influence how much alcohol one might be able to drink. And we also know, Dennis sort of touched on it there with binge drinking, in that this noticeable minority who cause harm to themselves are more inclined to be involved in binge drinking type culture, or sometimes a lack of knowledge, which sometimes people don't understand that drinking consistently over a lifetime can actually have an impact on your health when you get older. So there are these sorts of things we have to be aware of. We need to create more awareness amongst our Aboriginal people, but we need to also say to one another, how do we get there? And one of the best attributes that Dennis and I have is because we know, for a start, alcohol and drugs doesn't discriminate. So working as a black man and a white man together, we can say, well, we know that. And we use our intellect to be able to say, well, some of our work in Aboriginal Australia will have spin-off for the broader populations. And we need to understand that Aboriginal people, for instance, need to have non-Aboriginal people working with us, not for us. And we need to, Aboriginal Australians need to be told, it's our right to control the pathways out of our alcohol and drug poverty. And I've insisted on this with colleagues like Dennis, that I need you to work with me, and I'll work with you. And if the spin-off is that we have a good impact in the broader context, fine. But our focus is Aboriginal Australia.
I think Ted touched on an important point, and that is issues around price. We know from the evidence internationally and nationally that the biggest impact on levels of consumption in general and harmful consumption is the price of alcohol. The more it costs, the less people drink. And Ted mentioned Alice Springs. One of the things they did there was take off 4-litre casks of wine and 2-litre casks of port, and that takes the cheapest grog off the market. And what we saw as a result of those measures there were falls in levels of consumption, because people couldn't afford to buy as much alcohol, beer, for example, and get as much alcohol for the same amount. And what we saw were reductions in hospitalisations for alcohol-related problems, and it was a significant impact. And the importance of that program is that it didn't discriminate against Aboriginal people. That those price restrictions, those restrictions on availability, applied to the whole community. And as Ted said, harmful alcohol doesn't discriminate, and we need to be looking at measures that will reduce harm across the board. And I think one of the things that we've argued consistently is that any measures that aim to reduce alcohol consumption shouldn't unfairly or shouldn't discriminate at all against Aboriginal people. That if measures like those control measures are brought in, they have to apply to the whole community, not single out and discriminate against Aboriginal people.
We haven't got into the intimate discourse of talking about particular drugs, but one of the issues that many Aboriginal Australians are aware of now is that alcohol consumption during pregnancy is something of major concern to us, and this is not only something that is uniquely Australian, but certainly Indigenous peoples in other countries, and Dennis and I are both aware that there's a reaction to what we call fetal alcohol spectrum disorder or fetal alcohol syndrome in other countries like Canada that have alerted us in Australia that we need to be aware that babies in the womb need protecting, and I say this to all Aboriginal people, and again, this isn't uniquely Aboriginal, this isn't uniquely an Aboriginal problem. There are many issues that white Australia have to also confront in this regard, but we can do it together because it doesn't discriminate, and we just need to say to young parents and parents who are still having children, be aware that drinking and consuming drugs during pregnancy is going to have an impact on your unborn child. And Dennis mentioned, if we're going to give them a good start in life, it's very important that in the early years we know what's going on with our children. And we do know now, and I've worked with people like Fiona Stanley, Professor Fiona Stanley, a well-known paediatrician in this country, probably the best known, who has alerted many Aboriginal Australians and others to the fact that if children get that love and care and nurturing in their early years, they are already on a safe pathway. That's not to say that things might start to become awkward down the track, but if we can get them onto that safe pathway in early years, well then we've got hope.
Yeah, and we've talked a lot about alcohol and other drugs. I think the other thing to remember, especially in this context of early childhood development and the pregnancy, is tobacco smoking. There have been some dramatic reductions in levels of tobacco smoking amongst Aboriginal people nationally. The levels come down significantly from around 50% of Aboriginal people smoking 15 years ago. That's now down by about 20%. But I think the thing is there are still lots of Aboriginal people smoking, a much greater proportion than in the non-Aboriginal population. And there's a long way to go there as well. And as Ted said, it's particularly important during pregnancy that women don't smoke because of the effects that tobacco, nicotine has, and other components of cigarette smoke have on the unborn child.
It'd be great if we could actually have an intervention working across the board, and once the knowledge goes into our diverse Aboriginal populations that using drugs during pregnancy is a no-no, we would hope that our communities and our leaders can start to get a bit of traction as to how we might do that. It's not as simple as it seems. If people are aware, and many mothers are aware, but once you're addicted to a cigarette and you've got a pregnancy, you know, it's difficult. And some mothers still smoke during pregnancy, and people like me walk past and say, you shouldn't be doing that, young woman, but you know, they're still going to do it. So we have a lot of hard work ahead of us. The issue about our diversity, about us as Aboriginal Australians, and the context of us being Aboriginal Australians is something we can't talk about within 1 hour and completely get it right. But look, issues around racism, discrimination, indifference, marginalisation of us as Aboriginal Australians, these are all contributing factors to why I mentioned earlier in this discussion that Aboriginal Australians medicate to take away the pain of what has been a historical discourse of racism, indifference, intolerance, you know, name calling. And today in this country, I say to colleagues who live in Australia, this is a wonderful country to live in. I've travelled some other places in the world, and some of the Indigenous populations in other parts of the world are still coming through some of the issues that we've already confronted. Some of our brothers and sisters in the northern and the desert regions of Australia are going through similar historical discourse that we southerners, and I come from down south, I've lived in Perth or down south of Perth all of my life, what we've already gone through. So we know that you know, if we can get them to control our brothers and sisters to control the pathways, then that's going to assist us to feel good about what we're going to achieve. If you own something, and if you own the poverty, you own the alcohol issue, well then you're more likely to succeed in preventing the bad situations that occur when alcohol and drugs aren't treated with proper respect.
I think that ownership is really important. I think Ted, for all his life, Ted's been involved in the Aboriginal community health sector, the Aboriginal community control sector. And I think, you know, the reality is that most of the programs around the country to address alcohol and other drug-related harm have been initiated by Aboriginal community controlled health organisations, whether they be general community organisations, whether they be primary healthcare services or specialist services. They're dependent on funding from governments, and it's important that governments continue to fund those services and fund them directly. And I think one of the errors of government policy recently has been to challenge or to channel money that was intended to reduce methamphetamine related problems through the primary healthcare networks rather than directly to Aboriginal organisations who are much better equipped to know what the problems are and to deal with them directly.
And again, you know, the need for people to work with and not for is the premise that I would ask others to understand. And we do need the partnerships, but partnerships can have all the best intentions in the world and can fall flat. What we need is the fundamental principles that Aboriginal Australians need to control those pathways. I wanted to also mention the need for us to understand some other intricacies, and law enforcement, whilst it might not be an intricacy, law enforcement is so crucial to assisting Aboriginal communities and Aboriginal people to get this right. And law enforcement haven't got it right in the past. There is still a big mistrust of law enforcement in this country because Aboriginal Australians have been we've been abused in the past, and that it'll require a massive reconciliation for us and law enforcers to get this right. But it is necessary, Dennis. You know, the requirement of proper law enforcement around some of that violence that occurs in remote Australia, where sometimes law enforcers aren't available, or people in authority aren't taken seriously. And so we need to find a happy match here as to how our Aboriginal leaders and our Aboriginal community people can enforce certain rules of engagement around how we deal with alcohol and drugs. You know, the sly grogging. How do Aboriginal people tell their brothers and sisters, stop doing that? How do we work out what is a dry canteen and a wet canteen, and which community should have a boundary around it so that nobody who's drunk can come into that community and run amok? These are questions which only people in those sort of settings will have the answers to. We can suggest answers, but it's really at the local level that these people need to deliver, right?
I think the premise of our talk has been harnessing people's good intentions and working together. And several years ago, we did some work on the policing of volatile substance use, and there were some shining examples of where local law enforcement people worked in harmony with the communities, and they were successful in reducing volatile substance misuse. In other communities, the police visited occasionally, or they locked themselves in their compounds, and the policing was more or less a failure. And it's about building those partnerships and working together.
Yeah. So I'm going to quickly, I know we're running out of time in a sense, but I'm going to quickly tease Dennis in this next little while. The intervention of professional people in the health system, like the doctors and the addictions experts and that, and the use of pharmacotherapies, Dennis. I mean, we've also recognised that for a person who is addicted or dependent on or misusing alcohol and drugs, how do we find pathways out of the mishmash? And some of those pathways involve clinical interventions of a nature. And I might ask my colleague Dennis just to talk about some of those pathways and what and how we, as people working in research and trying to allay messages to our populations to find the right ways to do this.
Well, I think that you touched on it earlier, Ted, that what we need is a broad range of strategies. And I think, to me, one of the shining examples is work that's been conducted by our Aboriginal and non-Aboriginal colleagues at Central Australian Aboriginal Congress in Alice Springs. I think they recognised very early that there were lots of people coming into primary healthcare settings that had alcohol or other drug problems, and they were going from pillar to post to get support. So what Congress did was introduce a three-pronged strategy, so that someone who was identified as having a problem firstly was treated in the clinic. They were offered appropriate medications to help them come off their alcohol. Their medical and comorbid mental health problems were addressed there. They also had a psychosocial counselling support, so that they had Aboriginal health workers and psychologists to work with these people and help them come up with strategies to address their alcohol use. And they also had a social support system in which they help people to address their things like housing needs, employment, things like that. So a very broad strategy, all operating out of a primary healthcare centre. And then if people needed things like residential treatment, they could refer them on to Central Australian Alcohol Programs Unit, which is an Aboriginal rehab centre. So it's about coordinating those efforts, working together. But the thing was that, the strategy was devised by Aboriginal people for Aboriginal people, and people like Donna Archie, who's the CEO, have been very effective in getting non-Aboriginal staff to work under the direction and in harmony with the ideas of Aboriginal people in Alice Springs.
Yeah, but you and I both were in partnership with Donna and others before that when we were conducting the research to help set this up. So again, and I know Dennis is along with me, we're convinced that Aboriginal people need to lead the charge. But I want to thank Dennis and all of those non-Aboriginal people that assisted us to get that information about that program and how we might run it. And today we would call that an evidence-based way of going forward, because they've been collecting evidence and it seems to be quite effective.
And I think that's important what they've done because, Ted talked about gaps in services, and we know that there are in many regions of Australia there are gaps in specialist alcohol and other drug programs for Aboriginal people. But there are many more primary healthcare services than there are specialist alcohol and other drug agencies. And if we want to reach people, the way to go is by amalgamating and integrating those drug and alcohol programs with primary healthcare services. That way we will reach many more people that are in need.
Well, I'm certainly I'm impressed that we've got so far. The only other area, I suppose, is to talk about some of those issues that you and I have talked about in relation to the transition of young fellas through their life discourse and into an adult life, and what might be required in an educative sense.
Now, just because you guys can't see the chat screen, can you?
No.
So maybe if we go back to the, if you just click in and the 4 arrows, click that, and then you can see if people are asking questions.
All right.
Sorry about that.
Well, we can go into that now, eh? We've been
Yeah,
going for a while.
Yep. Yes.
Okay. Well, go on, Dennis. You do.
Okay. Well, what we'd like now is if anyone has any questions, we'll answer those.
We'll attempt to.
Yep.
Yep. Yeah. So while people are getting the questions up, we might just continue to discuss a few important issues, like there are issues around understanding which drugs are really hurting us, and it's still the case that alcohol and tobacco are still the biggest concerns for us. They create more health concerns for us than the others, but the new substance, methamphetamine, is obviously something which we're all dealing with at this very time. And we need to find ways that us Aboriginal Australians can find those pathways as well out of the awkward trauma that methamphetamine has caused for us.
Okay, we do have a couple of questions. Matt Stevens has asked if we have any views on the reintroduction of the banned drinkers register in the Northern Territory.
And again, we mentioned law enforcement earlier. And I think there's a place for a banned drinkers register or something of the nature of the banned drinker that convinces the communities at the local level that they're doing the right thing, because people who violate other people's spaces and do this while they're under the influence of alcohol in particular need to know that they can't do that. And somehow we need to develop a system not of penalties for sake of penalties, but people have to be held to account.
I think, and we know that the banned drinkers register was effective. We did some work with people from Central Australian Aboriginal Congress where we looked at emergency room and hospital admissions, and one of the things we found that following the period in which the banned drinkers register had been in place, once it was removed, there was a sharp increase in alcohol-related hospital admissions. And it's also, I think, as Ted said, it targets people who are causing harm, people who have been known to cause harm, whereas the alternative that was introduced following the banned drinkers register was to put policemen on all the liquor outlets, and if people couldn't show that they were going to a home, the alcohol was confiscated, which I think unfairly targeted Aboriginal people. And I think certainly, I'm not saying that the banned drinkers register is the only solution, but it can be part of a broader range of strategies. And
Rosalie asks, can you please talk about cashless healthy welfare card? Quickly to say to you, Rosalie, I've always been an opponent of cashless healthy welfare cards and those of a nature which are, again, very exclusive in the sense that I think they are basically trying to admit they can't deal with the poverty in Aboriginal Australia. I think it's quite discriminatory. I see that there is some good evidence that's coming out in relation to how some people are reacting to it. Some people are saying it's helping them out. Whereas in the broader sense, yeah, there are other Aboriginal Australians and people who are saying, well, I'm being caught up in it, I really don't need to be a part of this. But I think we're at the stage where we need a little bit more evidence before we can make comment on it properly. But I think as an Aboriginal man who demands that I be treated equally, I find it to be a discriminatory measure.
I agree, and I think there has been a report recently which come out saying that it's been successful. Talking to people on the ground in some of those trial communities. Firstly, it's been a very expensive exercise to introduce. It's not an economically neutral thing. It costs a lot to implement, and people on the ground say that there are certainly ways to circumvent it. So, and I agree with Ted. It impacts unfairly on Aboriginal people.
Yep. We could have a round around the mulberry tree discussion on that one, but yeah, look, there is a diversity of opinion. Some of the people who are seeing evidence now are suggesting that they've changed their mind about it. So I think you stand by what you think is your first stance on it. I've done that. I'm hoping that it has a positive impact, but I haven't seen that as yet in the broader sense.
And Paul Aylward's asked us to comment on the introduction of drug testing of welfare recipients and the potential impact on Aboriginal communities. I guess my view is that it is making things worse in many ways. If the reality is that there are a lot of people on welfare who can't work, who don't have the opportunity for jobs. They have problems as it is. They're taking alcohol and other drugs to self-medicate. And if you penalise them for being on welfare and taking drugs at the same time, you're also penalising their children. Families are dependent on those payments. And I think, to me, it's another insidious form of hurting people who are already in dire circumstances.
I agree with you completely, Dennis. The use of alcohol and drugs in Aboriginal Australia is, we believe, at least twofold, and more likely to be three- and fourfold, and in some drugs, in particular drugs, it's even higher. So again, Aboriginal Australians will be impacted on, and I believe there'll be a fair bit of trauma around this. We are barely living on the handout that we get from government at the moment. Our income levels are still only just over half of the average of non-Aboriginal Australians. This is an affluent country, everybody. This is one of the richest countries in the world. And for us, in 200 years, to still have a poverty-stricken population called the disadvantaged Indigenous population is something I can't fathom, and I'm not prepared to put up with it. And I will say to governments, these we try to find that word about we call them very small-minded sort of ways of trying to tackle this problem, and it's punitive. These punitive measures to try and deal with the poverty of Aboriginal Australians is starting to worry me more than they've ever worried me. So we still need to get our kids off of the dole if we can. We still need to get our people into jobs. We still need them in good houses. If they can't even access the pittance that is their welfare handout, well, then it's going to be far worse than what it is today.
As I said earlier on, no government of either of the main political parties has ever committed sufficient funds to close the gap between Aboriginal and non-Aboriginal
That's right.
people. And I think that it's disingenuous to say, oh, well, the budget can't stand it. You know, as Ted said, it's one of the richest countries in the world, and, you know, there are ways. You know, we don't have to continually cut taxes, especially on those better off segments of the society, and to, you know, it increases their standard of living, but it impacts unfairly on the poorer segments of our population, Aboriginal and non-Aboriginal.
Rightio, let's see if we can keep going here. There's another one here. With limited funding allocations and not enough to meet demand for drug and alcohol treatment in Aboriginal communities. Oh, where did that one go? How can PHNs best support and build capacity in AMS workforce to support people presenting with substance misuse? I think the PHNs, again, need to be very careful in how they engage with Aboriginal leaders in their regions. And when I use the word careful, I use it advisedly. The issues that Dennis and I mentioned earlier and how we connect is for non-Aboriginal colleagues to work with us, not for us. And again, I say that politely, because I know that with good intentions, sometimes we overstep the line. But I would say to those PHNs that are finding their way, don't get lost in the mire. Just continue to engage with your Aboriginal leaders in your region. We Aboriginal leaders are a bit precious when it comes down to our regional settings, so you need to make sure that you understand that we too have our own diversity and differences at the regional level, and it's important to try and engage with the broader Aboriginal leadership in your region rather than take particular individuals or particular families with you. This is something that we have to try and do to close it around all of the clans and the family clans.
Can I say, you know, we said that the move to channel that funding through PHNs was a negative thing, and I think, you know, we would still stand by that, but the reality is that's where the money's gone now, and I think it, you know, and, you know, talking to people on the ground all around the country, there are some PHNs that are doing this well and others not so well. And I think, you know, what we're talking about here is what our, you know, part of our talk's been about, and that's building good partnerships and taking direction from local Aboriginal people.
Yeah, and I think that this is an opportunity for us to all look at how we develop the best practice partnerships in relation to how we deliver resources into our populations, and this will be a great assessment for us to go through in about a year or two's time when we're able to look back and say, well, there were some PHNs, and I think there are some already developing PHNs and partnerships with Aboriginal Australia that are clearly can be clearly identified as good ways to go forward. But we need to make sure that we don't lose the plot in relation to how other PHNs are working, because, you know, it can all fall very foul very quickly. We might have a couple more. There's one here on marijuana. Marijuana is a very popular substance in remote communities, yet research I have conducted find most people do not consider it a problem, except for the very high cost, $50 per gram or whatever. Well, marijuana in effect is probably the first choice of many Aboriginal people these days. You know, apart from alcohol, which remains the most consistently used substance, along with tobacco, marijuana, could be considered to be a gateway drug into what we might call harder drugs, and the use of methamphetamine today might also be a stepping stone to other drugs. But let me say this to you, I'm very concerned about how people are perceiving marijuana. Marijuana is freely available right across the broad population of Australia. It's been around since, you know, who knows when. It is one of the drugs that people use to escape. People who live in remote settings aren't the only ones. It's very much available in Perth and in other cities. Aboriginal Australians today, in fact, are involved in the black market of marijuana, and it's a very complicated issue to try and provide law enforcement around, because you know all aspects of community, to me, are accessing drugs like marijuana. So Aboriginal Australians need to be aware that it can certainly have a negative impact on your health. I've worked with colleagues like Dennis, but I want to mention a woman who did some research on the comorbidity of marijuana and what was the comorbidity with mental health. And her name is Professor Marie Thiessen. And I remember when I first read this, and I thought, of course it is. Of course it is. Marijuana and mental health, when they develop, can develop comorbidities and have severe and traumatic outcomes for you. But that's not to say everybody is vulnerable. If you've already got a mental health issue and you start smoking marijuana, well, then you have double jeopardy, for instance. And vice versa, if you have a mental health issue and you start smoking marijuana, or if you smoke marijuana, it may develop a mental health issue for you. Aboriginal Australians are a stressed out population, very stressed out population, and so they're going to find ways to access marijuana. You know, if they're smoking cigarettes or if they're doing alcohol. And today we haven't talked about the use of other drugs together. What do we call that, Dennis? The
polydrug use.
Polydrug use, of course. And there's a lot of polydrug use goes on in our communities.
Can I just say too, I think, you know, different drugs have different degrees of harm, and I think that, you know, cannabis is widely used, but it's like all drugs. It's not a completely safe drug. Ted sort of mentioned mental health comorbidities. It's responsible for respiratory tract problems and bronchitis and things like that. So it's not completely neutral. One of the things we need to be careful about too is cannabis use amongst young people. I think just complete legalisation of it's not the answer. It needs to be regulated in the way that we regulate other drugs.
Yeah, and we have to be upfront with our populations as well. Look, the fact is that people are going to access these drugs. They're around. We think that when people go into prison that they don't get access to drugs. Wrong. They do. They get easier access to some of these drugs. So it's important when we researchers send out our information about drugs, not necessarily that we should stop and ban them all. That'd be great if we could enact the law right there and then, but you can't. And so we have to send out safe messages to people. And Dennis is right about respiratory tract. Why? Because people are using water bombs. People are sucking them up through other water implements. And you have to know that that's not a safe way to do business. And you have to know you shouldn't share your bongs. You have to know that if you're injecting drugs, don't share your needles. Don't use blunt needles. We want you to know things like, which we've tried on television. Don't go telling your kids to go to the fridge and get daddy another can of beer. Don't go doing smoking marijuana in front of your kids if you're hooked on it and you like to do it. There are some safe practices for you to make sure, as an older person, that you don't enhance the capacity within young people in relation to this. Every young person deserves to turn into an adult and be able to make up their own mind about what they access when they become an adult.
I think we'd like to thank you for the questions. I think we've come to the end of our time. I think it's good for us to have been here this morning to talk about these issues, and we'd like to thank you for listening to us and to thank you for your questions.
Yes, thank you everybody. It's been an experience. Thank you.
Thanks Ted and Dennis. Thanks very much for sharing your information.
Thank you, Joanne.
And I'll just thank you everybody. I'll just go to our contact details. Our next webinar, and thanks to Ted and Dennis. Our next webinar's in July or August. This webinar is being recorded and will be available on the website in a couple of weeks. If you need to get in contact with us, the contact details are on the exit slide. And yeah, our next webinar's in July or August. I'm not quite sure what the topic is yet, but we'll let you know on the website. Okay. Thanks very much, everybody.